Okay, so let's completely change topic and let's introduce il- what will become the next focus of this course. So you have an image, it was acquired somehow. You probably should know how it was acquired because it's relevant for your developing an algorithm. And you want to extract something out of it. What is it exactly that you want? Let's try to define this well, and let's see how humans are doing that now, because it tells us where information are in an image. So what would we ideally want from an image analysis algorithm? A biomarker. What's a biomarker? It's a measurable indicator of some biological state or condition. In general, most biomarkers that are used are from blood or from some other fluid samples like urine or cerebrospinal fluid or so on. Height, well, height and weight, they are not indicator of some condition, but like if you have high levels of amyloid protein in the cerebrospinal fluid, that's a marker of something related to Alzheimer's disease. The ideal concept that you will want is that you want to define a number of descriptors of an image, then identify the relevant ones for your task of interest, and finally fit them in a classifier if you want a categorical output, or a regressor if you want a numerical output. The question is, how do you quantify an image? That's, there's this sentence that human like to say, which is, well, I know it when I see it, but you can't really translate that into an algorithm. So let's start from this case. We have nuclear medicine. In nuclear medicine, we look at the concentration of the molecule of interest. We know beforehand that we need to look here, and we see that here is less than here. So we can quantify the concentration and see if that's high or low. But this opens a number of questions. You can maybe measure the mean and max intensity in one region, which of the two? In which region, by the way? I told you here. And if you get trained in neuroanatomy for not even that long, you can spot it quite well where here is, but if you need to tell it to a computer where the parietal cortex is, that's a very different issue. And you want to take the intensity, which one? You put the minimum, an area which includes all of that, something around the corner with some thresholding. So you see that in this case, which we will see, it's the simplest one. We have lots of open issues. Let's go to the CT. That's the same example that I used when I introduced CT scans. And here we have a tumor here. And what will you report? Well, what is classically done is report the major and minor axes to say we have a lesion of X millimeter in this direction and that direction, because maybe it's not circular. And you can also report area and volume. You can also classify the average intensity, even qualitatively, fat-like, water-like, tissue-like. Maybe that's relevant, but you open up a number of questions. What if there are multiple lesions? And if you want to report this measure, who is doing that? And here you're not saying, like with the brain, take a look in that specific area, because here a lesion can appear in every part of the lung, and by the way, in which part of the lung can change the prognosis. Let's make it more complex. That's a cardiac MRI, and there's a myocardial infarction here. And the question is, if you spot it, how do you describe it? So here you can say in the middle of the lateral wall, we have an hyperintensity and a thinner myocardium. But these are qualitative words. But there are many other even more complex findings, like that's one typical finding that you got from COVID-19, from interstitial pneumosis. That was really a light case, but you have what radiologists call a ground glass appearance. This is as compared to the normal lung, this one, here you have some kind of very, very fine powder-like appearance, which they say it looks like ground glass, which is fun, and this is fundamental for differential diagnosis, but that's all even another question, how do you translate that into an algorithm? So, okay, that's maybe a bit of a complex case about the report, but this is what a radiologist will say as clinically relevant information from this case. The report for this case was there are areas of clearing consolidation with central ground glass. So what this person meant is that there is consolidation here, the lung is full of something, and in the middle of it there is some ground glass, which is known as a reverse halo sign. They like to invent lots of categories and signs, so-called signs. Instead of ground glass surrounding a nodule, here there is an opacity within the intensity. There is also the atoll sign as the consolidation clears away from peripheries. So the shape here looks like an atoll. So it's that's not something that you will know how to put into an algorithm. Again, for neurology, things are relatively easier. Alzheimer's disease starts to appear with atrophy, especially in some very specific regions. And here in red we have the hippocampus, in blue the entorhinal cortex, and the perirenal cortex in green. And so you know where to look, you draw the boundaries, someone, you need to decide who does that. And here you say, okay, the volume is reduced, but suppose that you actually measure the volume, and so that's the same subject. So you could probably, if you happen to know to have a pre and post count of the same subject, you say the volume here went to 20 ml to 10 ml. This is bad. But if you have 15 ml, the range in the normal population for the volume of the hippocampus, as contoured by different operators, it has really lots of variance. So it's even the volume itself is not enough. So after confounding you a lot by showing all the issues that are present in when trying to interpret an image, we can get some answers. The first one is that this is not trivial. And we can think about some orders of features that we can get from an image. The first one is that of zero order features, which include which describe shapes of an area. So the area, the volume, if you're talking a 3D scan, the surface of this volume, the diameter, the sphericity, and things like that, how much is fractal versus smooth, and so on. The first order features relate to the intensity, which means the values that you find within that region of intensity in the image. And they can include everything that you can do on an histogram, because you take all the pixels within the segmentation, but you need to have someone who did the segmentation, of course. And then you extract minimum value, maximum values, mean, kurtosis, skewness, and whatever you might come up with. Then there are the most important but hardest to quantify. Oh, by the way, when you do that, we will see that in the notebook, when you work on the histogram, you need to think beforehand in which unit your image is. Because suppose you have a CT, okay, you have a CT, you can just take mean Hounsfield number is 0, that's water. But if you do it in, even in PET, you say 100 kilobecquerels over cc. What does it mean? Because it turns out that the amount of radioactivity that you get is influenced by how much you have injected in total, how much the patient weighs, because it's every molecule that you inject diffuses all over the body. The body composition, because the average uptake of fat cells is much lower than muscular cells. And then of the kinetic properties of whatever was going on in this person's body. Because if you're looking at the brain and this person's leg was super active because, I don't know, it has just a simple inflammation, less was entering the brain, so it might be lower overall without any specific reason, any pathology-related reason. But even when you're looking at volumes, volumes can be expressed in milliliters, but this might be, that's something that might correlate a lot with patient weight or patient height, so the volume per se might not be meaningful. But the intensity, most of all, you need to, when you say, well, but in patient A it's very bright and in patient B is very dark, translating dark and bright into number without, it probably needs to do some kind of rescaling, and how to do that is very relevant. Then you have the most important part, but most difficult to put into practice, which is the so-called second order features, which are patterns and textures, which describes facts like, we say, the ground glass appearance, something can appear patchy, noisy, stringy, blobby, or whatever. Now, that led to the formation of the field of radiomics, which nowadays is mostly disappearing. I think you asked me pretty luckily enough, but the basic concepts are relevant to us, which was a machine learning approach to medical image analysis. Now, we already talked about pattern. What's pattern is a regularity in the word, in a design, or in some idea. And we care because if I show you this, you don't have most likely don't have any clue what it is. If I show you this, which by the way is not even a picture, is a picture transformed into a cartoon, you probably can guess what it is. And that's like a brick wall before the sky. And this probably can also tell you that these are tiles that are made in a stone-like way. So the pattern, the presence of these lines at a regular spacing told you that this is a wall made of bricks or tiles or whatever. While the shape actually wasn't telling you anything. These are two rectangles at an angle. So what they invented really lots of metrics to try to describe the pattern present in an image. So like one way was to give an image, this is 4 levels of grays with 4 by 4 pixels. how often, if you have a certain intensity in one pixel, the pixel on the right has another intensity. So like you say, intensity 1 in one pixel and intensity 1 in pixel on the right, 0 cases. Intensity 1, intensity 2 on the right in 3 cases, 1, 2, and 3. And so on, you go on to fill it. You can do the same for the other direction. You can do that in vertical, in diagonal, and whatever. This concept actually goes back to, was introduced in 1973 by Haralick, and he was doing satellite analysis of satellite images for automatic detection of what's in an area, whether it was buildings or crops or woods or forests or so on. So that texture can be evaluated as fine, coarse, smooth, rippled, molded, irregular, lineated, and so on. And indeed, it makes example that in the humid tropics, fine textures can be indicative of one specific kind of rock, while coarse can be indicative of sedimentary rocks, and so on. And texture, that's the most interesting part, is an innate property of virtually all surfaces. The grain of wood, the weave of a fabric, the patterns of crop in the field, in whatever kinds. Like if I go back to the lung image, this kind of normal lung, even this presence of these kind of strings here and there, which by the way are the alveoli and the bronchi here, it's really what let us know that the lung is present here. So we can see what happens when you do that, and if you compute the co-occurrence matrix on uncorrelated noise, we get this. This is the co-occurrence matrix. While if you have a blobby structure, we can see a very definite pattern, because if we have blobs, indeed the most likely intensity that we have next to one pixel is the same intensity. If we have a random structure, we have no correlations. But this is the co-occurrence matrix, we have said. So that means that in this case, we have, I don't know, 1, 2, 3, 4, 5, probably 8 by 8 numbers. So we have 64 numbers, and you don't do much with 64 numbers. So what did they do with the matrices? You computed some statistics on the matrices, and you could define lots of them, like the entropy, the average, the variance, and so on. However, the co-occurrence matrix has many factors influencing it: the number of pixels used, the spatial scale, the gray level discretization. So the spatial scale, I've defined the co-occurrence matrix at the beginning as the matrix of how the pixel is related to the next one on the right. Do you see any specific reason to see the relation between a pixel and the one just on the right? You could compute it maybe in the, like even with satellite imaging that Haralick was working with, it could have made more sense to talk about X millimeters to the right. And indeed, if with this blobby structure, if I compute it with 3 pixels on the right instead of the pixel on the right, I get this uncorrelated co-occurrence matrix, because the blobs have a spatial scale of 3 millimeters. And that's informative, because it's telling you at which dimension you have correlation and which one you don't. Number of pixels, very simply, if you have more pixels in the input image, the number here will be higher in the co-occurrence matrix because you have more entries. gray level discretization, if you take these 255 gray levels, and in CT actually there are more, you get a sparse matrix. So it was used to reduce the number of gray levels, but if you went to 8 or 32, 32 might have been fine, but 8 would have been okay, but you were losing some details, and with 4 you get no information because you have too little entries. So when people started to work a lot on that, they started inventing not only the co-occurrence matrix, but so this there was a standardization initiative. We're talking about 2021, 2022, not when this was introduced in medicine, when deep learning was already going much faster. Probably they started earlier, 2018 or so. They said, okay, this is going a mess because we have many matrices, the co-occurrence and all these other ones, and many others that each one can define in multiple ways, depending if you take the pixel on the right, on the left, only the cross or also the diagonal, and so on. Then we compute some metrics summarizing the matrices. Then we have multiple options like the gray level discretization and the resampling. And when we do the discretization, first we also need to do an intensity scaling. So everyone was coming up with different things and options. And even in here, we're getting like 200 descriptors, each of which can be computed at a different spatial scale and with different options. So you can see that this is not really going very far. Now, just to show a typical pipeline analysis, what you need to do was identifying the region over which to extract the feature. So you needed a segmentation, either manual or automatic, and in case it was automatic, you needed to decide which algorithm and so on. You had to extract potentially infinite measures, features, because when you start to deal with even just a spatial scale, which can be extremely relevant, so it's not something to discard, these 300 features blow up. Then with some uncrafted procedures, you were supposed to remove all the features that you know that were unreliable, if you were able to know that. And this is done in a way like with augmentation. Nowadays it's augmentation. Then you remove all of the redundant features. And finally, you can feed everything to a classifier or regressor. But you could see why that was, I don't think they ever got some good results out of this approach, and machine learning worked much, much better. Now, just a quick note to finish that. When you're running a classification, you always need to keep in mind, that's probably what you're seeing with Professor Bernasconi, the difference between a research application versus a diagnostic application. So for a useful diagnostic procedure, you need a classifier that outputs a variable which distribution between classes is absolutely non-overlapping, because otherwise you have an area under the curve, a sensitivity and accuracy that are completely tragic. For research purposes, instead, it might be interesting to find some differences at that are variables that are significant at the group level. So if you know that in general, people with one pathology have a statistically increased expression of one marker, that can be a good finding, even if it's not sufficient at the individual level. Physicians like to talk a lot about p-value, even if statisticians tells them they should focus on effect size, on other more reliable metrics. To summarize, like suppose that you are analyzing the difference in height between men and women, probably you get two distributions that are like that. Men are taller in general, but if I tell you that someone is 1 meter and 65, 75, you have probably it's 60% a man, 40% a woman. The accuracy is terrible. But if you measure the p-value over enough samples, the more you increase samples, and with big data, it's easy to work with thousands of samples, you can say men on average are very reliably known to be taller on average. However, when you're working with diagnosis, you want to work in a situation like this, at least like this. You want clearly two different separation, and then you have you might have metrics like the effect size. Here, maybe the most relevant can be the p-values corrected for multiple comparison and whatnot. It tells you how much your discovery is reliable. But if you're talking about a classifier for clinical use, you want a metric like this, like the Cohen-Dean is my favorite one, kind of, that tells you, in case of Gaussian distribution, how separated the two groups are. And so when you are applying a classification, you want to extract some parameter that fits well according to that direction. Okay.